I'm sort of here a bit by accident, really. I'm a consultant psychiatrist, and actually my primary sort of qualification is in old age psychiatry, and my main interest is in dementia. But I also have looked after the ECT service in this trust where I work in Oxford Health. And it's really through that I came into hearing about ketamine. And I'll talk a little bit about this. But I need to start with conflicts of interest statement. That's sort of conventional these days. So Janssen are setting up a trial of S-ketamine, intranasal S-ketamine, and Oxford is going to be one of the sites for those trials. So they will pay me some money, which will go into an account for research that I do. Okay, it doesn't come directly to me, and it's less than £5,000. I also lead a commercial clinic, which is run within the NHS for the assessment and administration of ketamine for treatment-resistant depression, which has just started up. So, again, I don't get paid anything for that personally, but my trust, my employer, would get an income which then could be used for the treatment of other of NHS patients. And just to say a little bit more about that phase 3 program that Janssen are doing, the FDA in America have designated intranasal S-ketamine as a breakthrough, and that means that it's something that can treat a serious or life-threatening disease. The drug may demonstrate substantial improvement over existing therapies, and the FDA will expedite the development and review of such a drug. And in fact, it's the only mental health drug with this designation. And just what I remember, S-ketamine is one of the racemic versions of ketamine. It comes in 2 mirror images, one of which is S-ketamine. Normally, when we talk about ketamine, we mean both mirror images. So current antidepressant drugs are all based on boosting monoamines, such as serotonin, dopamine, and noradrenaline. One of the problems is that they take a long time to work, and often people don't respond to one or more of those drugs. And although many of the people who commit suicide are not taking antidepressants, a lot of them are, and that's the number of people in the UK that committed suicide in 2011. The current treatments, a sort of typical hierarchy, if you like, of treatments that we use for people with depressive illness that come to us in secondary care, so have been referred by their GPs. They've usually been on an SSRI first, and quite a lot of them will also have been on an SNRI as well. They've switched to a second class. And then what will typically happen in secondary care is that that strategy will be augmented, so they'll be on 2 drugs at the same time. And then if those don't work, typically what happens is that various other combinations of SNRIs and lithium and sometimes, depending if there's a bipolar element, a mood stabilizer are used. We don't use very much of the monoamine oxidase inhibitors these days, but that would definitely be the next step. The reason is that there are dietary restrictions if you take monoamine oxidase inhibitors. And then for people who are very severe and very treatment resistant, sometimes they come to ECT. So just to give some idea of the numbers on this, in the UK, probably about 3% of the population suffer from depression, of which about a third have moderate or severe depression, so somewhere around 630,000. And when it comes to sort of the more treatment-resistant types of depression, about 25% of those with moderate to severe depression will have a significant degree of treatment resistance. Now, people, I'm talking drugs, okay, people will usually have some form of psychological therapy as well, typically cognitive behavioral therapy. And so that's about 158,000. And of those, a very small proportion will go on to get ECT. Now, in fact, these numbers here, 5,000 of those, that was an estimate. And I looked up the exact number of people that are receiving ECT in the UK at the moment. And it's gone down from 9,000 in 2002 to just under 2,000 in 2012-13. So there's been a very dramatic reduction down to about a fifth over the last 10 years or so. And that's partly been driven by a change in NICE guidance on the use of ECT. The vast majority of these patients are referred for treatment-resistant depression. And just to give a sort of idea of the severity, these are data that's taken from the ECT Accreditation Service, which does an extensive audit on almost all the ECT suites that administer ECT in the UK. And you can see here that about 65% of people are severely ill or amongst the most severely ill. And this is the assessment of the secondary care psychiatrists. So their gradation, if you like, as to what constitutes severely ill is their bar, if you like, would be higher than it would be for somebody, say, working in general practice. And the physician-rated outcome of those courses of ECT was this. So you can see that we know that ECT is an effective treatment, but of course it's a treatment that's controversial for very good reasons. It was dramatically overused, and it causes side effects. And whilst the most common effect on cognitive function is that it improves after ECT, there is an effect on autobiographical memory, so personal memories, where people sometimes complain of a loss of personal memories. So, and when we talk to patients about that where possible, we have to balance that. Well, we always have to balance the risks and benefits. So it's not a treatment that you go into lightly. And by and large, it's reserved for people who really have tried pretty much everything else. But it's not a satisfactory treatment. Lots of people are too frightened to have it because of its history and reputation. Undeserved, I think, generally. Ketamine has been, I won't go into the history of how ketamine became identified as potentially a useful antidepressant. But this summarizes the data of the recent interest, which sort of kicked off really with Berman's study in 2000. And these studies here, each line represents a study, and the extent to which it's to the left here indicates the extent to which it favors ketamine as a treatment for treatment-resistant depression. These are all treatment-resistant depression studies. So these are the non-placebo-controlled studies, and these are the placebo-controlled studies. Now, in fact, they're not really placebo-controlled, so it's pretty difficult to find a placebo for ketamine, because, you know, you take ketamine, you know you've taken it. But these at least attempted some sort of placebo. Some of these are, in fact, saline-controlled, and these are all studies of intravenous ketamine, low-dose intravenous ketamine that's administered over 40 minutes, 0.5 milligrams per kilogram. And you can see that there's a very consistent effect that is clearly significant. And just to put this into context, you need to treat, this here is the number of patients you need to treat for one of those to get to remit, in other words, to get to the point that you wouldn't know that they were depressed at all, because they would be just as depressed as, you know, somebody who wasn't complaining of depression. So that's remission. Okay, so you'd need to treat 5 patients, for one of them to remit at 24 hours, 6 for one of those to still be remitted at 3 days, and 7 for one of them to be still remitted at 7 days. So and for comparison, that's pretty good. Antidepressants typically come out at about 3 or 4, Viagra's 2. And this is an RCT of ketamine versus, so this is the biggest trial that's been done to date. And in this, they use Midazolam, intravenous Midazolam, as the comparator. It's not a perfect placebo, but it's the best that has been identified so far. It tends to cause more amnesia for the event than ketamine. And what you can see is that here at day 1, the rate of response, so response means a 50% reduction in the Montgomery-Åsberg Depression Rating Scale, of 25% in the Midazolam group compared to 62% roughly in the ketamine group. And you can see that this effect sort of diminishes slightly over the subsequent 3 days, and in fact by day 7 it's not significant, although you can see that the effect is still there, and the number needed to treat for a response at 24 hours is 2.8. So that's a very potent drug. Now just to say a little bit about the study that we've done and the follow-on from that. This was a study that was sponsored by the National Institute of Health Research in the UK, to whom we're very grateful for their funding. The person who did most of the work on the study, people that did most of the work on the study were Peter Diamond and Steph Atkinson. I'm very grateful to them for their help. And the anaesthetists that we involved were Andrew Farmery and Jag Haldar. We were terribly pleased with this acronym. Resistant depression, ketamine infusion treatment evaluation. If you go to Oxford, you see red kites all down, or everywhere. So they're a new and, sort of, well, last 10 years, I suppose, dramatic addition to the landscape. And I'm rather think that ketamine is a bit like that. But there are sort of associations of going as high as a kite that are perhaps not they have other connotations. So just to give you a sense of where we're doing things, we're doing a very, very medical approach. Okay, so what happens is that the reason that we were able to do this trial is because we did it during ECT sessions. So some patients are getting ECT, but the patients who are getting ketamine are not. Okay, they just happen to be going through the department at the same time. And the reason for that is that we've got a consultant anaesthetist there, doing an anaesthetic for the ECT. So these two beds here have patients who are recovering after their anaesthetic for ECT. And in this bed here, we've got somebody who's having a ketamine infusion. Now, in fact, the curtains are usually drawn. We drew them back to just illustrate it. But the patient who's got somebody who's having ketamine would have somebody sitting with them, generally. But this is I have to say, can sometimes be quite a noisy environment. We try to keep it as quiet as we can, but it is what it is. People are coming through, and once they're recovered, they're getting off the trolley and going through to have a cup of tea. But this is what we're giving the patients: IV infusions of 0.5 milligrams per kilogram. And one of the other reasons for doing it in the ECT suite was that being realistic, the place where ketamine is most likely to find its first use is as an alternative to ECT. So the staff who are in this suite are used to dealing with people who are distressed often, who are ill, may have comorbidities. In fact, the average age of the people that has ECT is probably in their late 60s. So we get a lot of patients who are over 65. Half of them are over 65, but that's not the case with the ketamine, as I'll explain. So it's a sort of pragmatic thing about how we could get the study done, to be honest with you. So this was primarily a safety study, and the main reasons were to establish how people reacted during the infusion, whether it affected their cognitive function, because there's quite good evidence that people who take a lot of ketamine over a long period and high doses seem to have a degree of cognitive impairment, and in particular, obviously, the bladder dysfunction that goes with very heavy ketamine use. So people who use grams of ketamine daily, not infrequently or from time to time, will develop the sort of bladder trouble that means that they have to have their bladders removed and they have to have a bag for their urine for the rest of their lives. So terrible, terrible thing to happen. And we were exploring, obviously, the acute and chronic effects on mood as well. It was a case series. 15 patients got three treatments over 3 weeks, so once a week, and 13 patients got 6 treatments over 3 weeks. The people that we recruited were generally referred by secondary care psychiatrists, but we also had a few self-referrals who had come to us through a newspaper advert. We put 2 adverts in the Oxford Times and some posters, and we also had a website with an email box. And what happened was that we we sort of started off with mainly referrals from clinicians, but the self-referrals soon started to pick up quite dramatically. And the blue line refers to the number of patients who were actually recruited into the study by clinicians who were clinician referred, and this one line refers to those who were self-referred. So the clinicians had it wasn't a perfect hit rate, but it was higher than the self-referrals, as you'd expect. And the principal reason for screen failure, in other words, people contacting us who didn't then go on into the trial, was that once we'd told them that we wanted to hear from their GP, they didn't come back to us. Okay? But other reasons were that it was too far from Oxford, or they weren't depressed enough, or they couldn't get somebody to accompany them. The dissociative effects were experienced by almost everybody, but not everybody, and with a sort of, so people get things sound more crisp, and noises have a metallic quality to them. The sense of time's distorted. People feel dissociated from their bodies, and things look different as well. So, and I'll mention that in a moment. About half of them found that rather aversive, and although I've put unrelated to mood response, it seemed that the extent of these dissociative symptoms seems to be is unrelated to mood response across the sample, but within individuals, we do think that some people will appear to have a better response if they have a degree of if they have a degree of dissociation. They'll sometimes say, well, that one just didn't do anything for me, and it doesn't do anything for their mood. It seemed to be unrelated to the environmental noise, and was very quick to stop at the end of the infusion. So just an illustration. So this was the curtain that was round the bay. We've changed it to colour blue because one of the patients explained that he thought it looked a bit like Thatcher, and he had in mind this scarf cartoon here. So he turned that into in his mind's eye under the ketamine to something quite ghoulish. As far as the tolerability goes, where we're doing 3 infusions over 3 weeks, 3 of them withdrew. One because they had a panic attack after 9 minutes, one developed a chest infection, was unrelated, and one was sick and didn't appear to improve. 5 of the 13 withdrew during the second phase mainly because they didn't get any sustained benefit. It just didn't see that they had an initial benefit, but it wasn't enough, and they couldn't see the point of going on with something that didn't seem to be helping them. The worst side effect that we had was that one person had a vasovagal episode, so they fainted, had a really quite marked drop in blood pressure after 10 minutes, and it lasted for 10 minutes, and I have to say I was quite worried about them, and I was glad there was an anaesthetist there. So this has been reported in one other study as well. I don't know if it's at all relevant, but the person was of Chinese extraction. So in general, but that's the only one that we've had. The other major side effects, well, I don't know if you call this a side effect, but we had one patient who woke up on the bathroom floor surrounded by tablets, and one took an overdose with intent, but then went to A&E. So, in a way, we were lucky to get away with this. But these are patients who are often very sick, and that's one of the risks you take of doing this sort of research, is that, bad things will happen during it. again, the mood instability that some people experienced seemed to be broadly similar to that which was prior to the infusion. So this is the sort of thing that happened. We had one episode of cystitis, but the patient clearly related it to improvement in her mood. And fatigue was common and brief. But by brief, I mean it was limited to the afternoon of following the infusion. In terms of memory function, at 21 days, so this was a subjective memory questionnaire, just how is your memory on I think 20 odd items. And the change in score above the line means that it's better, and if it's below the line, it's worse. So you can see that both in those who were getting 3 and those who were getting 6 infusions, the memory improved across, generally across each, well, it improved for most of the patients. And similarly with remembering a story, so this is a more objective measure of recall. So this was the, where are we? Yeah, so there's an immediate, which is the pale bar, and the delayed recall, which is the darker bar, and they broadly parallel each other. This patient here had a sort of perfect score on the first session, so he couldn't improve on it, in fact, so he got a bit worse. So in terms of response rate, the definition that we used was a 50% reduction in the Beck Depression Inventory 4 to 7 days after the final treatment. So note that we didn't use a definition that was based on 1-day response rate. And the response was 29% at 4 to 7 days after final treatment, and and of the total sample, 14% remitted. And the duration of the response was really highly variable. So for some patients, it was as long as 168 days after just up to 6 infusions. As far as suicidal intent goes, we noticed amongst the responders a big reduction in the level of suicidal intent as measured on the Hamilton, that parallels this study here, which was being done at Harvard by Larkin, who gave people who'd turned up in casualty, having either tried to commit suicide or with the intent to commit suicide. It gave them ketamine infusion, and this is their scores on the suicidal ideation item of the Madras before the ketamine infusion, and then for the 10 days afterwards on average. So it seemed to have an enduring and dramatic effect on their suicidality. So that was the study that we were, if you like, the NIHR funded us to do. Since then, we've gone on and we treated a total of 56 patients. That includes the 28 who are in the study. Sorry, and the 17 there is that figure's wrong. And we've given a total of, as of yesterday, 585 infusions. And the response rate at 3 days remains about 30%, and but further treatment or people who've remitted, it's about 18%. And I just wanted to show you. So this is if you like, some patients who are currently in treatment. So this is the level of the numbers of infusions that people have had, and they've also had some supplementary ketamine as well, to see whether we could maintain the effect. So this is an example of somebody who has had a dramatic response to ketamine. In fact, she responded for 9 months after just 2 infusions. You know, you have to wonder whether that's real or not, but that's what happened. So sorry, I should say these are scores that are submitted by text each day or each week on a depression scale. And high scores are bad, low scores are good. The red is mania scale. This is somebody who clearly didn't respond at all, just had very brief, limited scores. So this top panel shows somebody who's had a good response after 3, then about 3 months later they're starting to look as if they're relapsing, so they've had some more, they've got better again, and we've given them prophylactic ketamine. Each of these bars represents an infusion, and then not doing so well at this point here. And you can see that they're changing their medication as well. Just for time, I think I'll move on to the next one illustrates a point here that sometimes people seem to get resistant to the ketamine, so they've had good benefit here and here and here, but it doesn't seem, somehow doesn't seem to be working so well. And what we've tended to find with some of these patients who've had similar experience is that you delay things, you leave them off it for a while, and then you come back to it, and they still then appear to respond again. We've tried adding in various other other glutamatergic agents and haven't found anything that's particularly worked. In our hands, when we gave ketamine as the anesthetic for ECT, it didn't seem to make any difference. So here's a patient who's become resistant to ketamine, has had ECT, got better, relapsed, had ECT with ketamine as the anesthetic, and got better in exactly the same way as they did with the ECT, no different, and has then had a further course of ECT. She's very, very sick, but currently continues actually to be quite well on maintenance ketamine infusions every 2 weeks. Here's somebody whose life was dramatically changed by ketamine. He had a dramatic improvement here, and this was a self-limiting relapse, but during this period here, he was able to get one of the most competitive academic jobs in the country, which he certainly wouldn't have been able to get if he'd been here. And he continues to have, although things look more disturbed here, but he's continuing to have ketamine, and it keeps him on the level. This is somebody who has been coming up for the last 4 years, getting ketamine infusions every 2 weeks. And we've tried various different things to see if it would make any difference to this duration. She spends a week in bed, very depressed, unable to do anything. But the first week she's able to get out. And in fact, more recently, she's added in a change to antidepressants, and seems to be getting a little bit better. But none of the things that we've used to try and maintain this have really made very much difference. So what we need to do is find better maintenance strategies, and that might mean altering the frequency, dose, and duration of the infusions, or adding, in particular, things by ketamine by different routes, or other. If somebody finds another agent, that would be great. I'm going to have to skip on, actually. So just to say one thing about how it might work. What ketamine does to neurons in a petri dish is it results in rapid outgrowth of these dendritic spines. And if you think of an unhealthy tree with its twigs retracted, or that perhaps due to being abused as a child, then that's what happens as a control. And this is what happens with ketamine in the presence of various neurotrophic factors. So just to say a little bit more about adoption of ketamine in the NHS, the first thing that we're going to need to do is to find a plausible 6 months maintenance strategy, and that involves new routes. But of course, the problem is if you're sending people away with ketamine, there's going to be a risk of illegal diversion. And that is a problem for us in a medical environment. I've mentioned sustaining agents. It would be great if we could just or get those spines that retract after a while to remain extended and converted into a different form that makes them more stable. We will, of course, need to do a large trial, particularly based on those who respond, and to do that we're going to need to get more hospital sites that are prepared to deliver ketamine. We're the only place in the country pretty much that does it at the moment. And really until then, the way that we're going to best advance this cause is through the collection of structured data of the sort that I've shown you. And there will be, obviously, and that will need to be through commercial clinics, because there's no way that the NHS is going to, that NICE is going to agree to fund this sort of treatment without evidence that's comparable for that it would demand of any other treatment. So the other thing that we need to get it adopted in the NHS is sort of press like this, which is from the Huffington Post, which was what greeted our study, which I was really pleased with. Party drug ketamine could help treat severe depression, says yet another study. I was pleased with that. That was great. So that's a sort of balance thing. And I think I'll leave it at that. Thank you very much.